Welcome back to the Dr. Cliff Show. In today's episode, we're talking about the surprising link between hearing loss and dementia with a special guest. Coming up. All right, we are back live for another episode of the Dr. Cliff Show. I'm Cliff Olson, Doctor of Audiology and founder of Applied Hearing Solutions in Phoenix, Arizona, and I am here today with my co-host.
Hello, everybody. My name's Rachael Cook. I'm also an audiologist at Applied Hearing Solutions. Thanks for coming back to join us today. So we're talking about two huge problems that we are facing globally at the moment, which is really increasing rates of hearing loss and increasing rates of cognitive decline. And both of these are occurring at higher rates in aging populations. So just to kind of set the scene here, for hearing loss in particular, we've actually got a graphic to start this right on off. And about a third of the adults over the age of 65 are actually experiencing some form of hearing loss. And we've got 2/3 of adults over the age of 75 that are experiencing hearing loss as well. And just 38 million people in the US alone, and that number is staggering. Now, in terms of dementia or cognitive decline or neurocognitive disorders, the Lancet Public Health estimates that by 2050, there's going to be 153 million people globally with varying rates of dementia as well. And so both of these problems are pretty significant, if you ask me.
Yeah, I would consider it even a health crisis.
Yes. Oh, most definitely. So we already did an episode previously, our 8th episode actually, which was titled Hearing Loss and Dementia and How Hearing Aids Can Help. And on this episode, we went through several examples of really promising research about hearing loss treatment and cognition overall. And so if you want to dive further into this topic after the video today, you can go back and watch that episode as well. But today's episode is really exciting because we are actually joined in studio by the researcher and author of some of this really incredible new research. But before we get into all of that, if you have not already liked and subscribed, make sure that you do that so that you never miss any of our newly released content. And be sure to ask your questions on this topic early and often so that we can answer them at the end.
Yeah, you definitely will not want to have your questions go unanswered in today's episode once you find out who our guest is. So that's exciting. Now, before we get into it, though, who doesn't love a good round of golf? You know, I was actually talking with some individuals here at the office today, and the topic came up of someone had called in, they had a really good round of golf, and then when they got back home, they realized that their hearing aid was missing from their ear. And now I don't know if that's a worthwhile trade-off to have a really good round of golf, but you lose your hearing aid on the golf course. I guess he had a really violent backswing or something like that. And that's not a problem if you lose a hearing aid, because you can file your loss and damage claim and you'll get a brand new hearing aid replacement, but you can only use that one time per hearing aid that you lose, and that's exactly why you need ESCO. So ESCO specializes in providing loss and damage and repair insurance coverage for your hearing aids, so you do not have to pay for expensive repairs or buy new hearing aids before you are ready. They have a variety of different coverage plans, including ones that if you lose your hearing aids and you use your loss and damage claim, they can reinstate that loss and damage claim for you. And you can actually get a price quote for your exact hearing aids on their website. So if you want to go do that, head over to esco.com/Dr. Cliff. Dr. Cliff Show viewers get a $10 Visa gift card just for registering your hearing aids. Now, thank you, ESCO, but let's go ahead and jump right into who our special guest is today.
Well, today we are joined in studio by Dr. Douglas Beck. He began his professional career at the House Ear Institute before becoming the director of audiology at St. Louis University, then went on to co-found an audiology private practice and became the president and editor-in-chief of audiologyonline.com, speechpathology.com, and healthyhearing.com. Dr. Beck joined Oticon in August of 2005, and in 2019, he was promoted to Vice President of Academic Sciences. Dr. Beck retired from Oticon in March 2022, and in April of 2022, in a surprising Tom Brady-like comeback here, Dr. Beck became the Vice President of Clinical Sciences at Cognivue, which is a company that develops and distributes cognition screening equipment. So Dr. Beck is one of the most prolific authors in audiology with over 200 publications and has presented more than 1,000 lectures, keynote addresses, webinars, and other professional presentations. So, oh, and he's also apparently really great at playing guitar. So thank you so much for joining us. We are so happy to have you with us today.
Thank you, Rachel. It's a pleasure to be here. Thank you, Cliff, for the kind invitation.
You know, we actually had talked about getting together and doing some podcast episodes. This was pre-COVID when we were talking about that, and then COVID basically put the complete kibosh on that. But you're always the individual that I wanted to have on the show whenever we actually started a show.
Well,
and so I am extremely excited to have you on today, and particularly for this topic, which is a growing topic inside of our world of audiology, and it's a growing topic outside of audiology as well. You know, in the past several years, increased attention on it. You know, I can remember the first article that I even read linking the hearing loss and dementia together was 2011 with Dr. Frank Lin, right? Yeah. And then within the past few years, there was one that stood out to me. So the Lancet Commission came out and rated hearing loss as the leading potentially modifiable risk factor for hearing loss.
Well, so they did that twice. The first one they did was 2017, and they modified it a little bit. They said there's 12 modifiable risk factors, and hearing loss was the most significant, as you had mentioned. And they assigned it a number, which is 8.2%. So that's a PAF, population attributable factor. And it becomes remarkably important when you think of things like the other modifiable factors can be social isolation, can be diabetes, alcoholism, drug abuse, things like that, air pollution.
Well, we've actually got a graphic for this. We can pull that up. We've got the whole commission map here. And so we'll get that up here in a second, and that's got all of the...
Right, and when you think about all of those things and you put them all together, what the Lancet said in 2020, which was Gil Livingston and his colleagues, was that if you put all of those things together, that's about 40% of your dementia risk. So when you think about this, the question that they asked at Lancet is, what is your risk of having dementia, of developing dementia as you age? And it turns out these 12 modifiable risk factors are 40% or so of your risk. So the other 60% is, you know, aging and natural things that happen as we age. We do tend to slow down. We do tend to process at a little bit slower speed. And there's two types of intelligence, right? You have fluid intelligence and crystal intelligence, and we won't go into all of that stuff. But as you aged, your intelligence of your crystallized intelligence remains pretty much the same. Fluid intelligence changes. So we do expect changes in the central nervous system as we age, but what Lancet said in 2020 is that hearing loss was the single most significant modifiable risk factor.
Yeah, and you know, like you said, we do expect to have some rate of cognitive decline as we get older. Like that is expected. You know, when you actually had written an article, a deeper dive into cognition and audiology in 2022, emerging relationships between audition and cognition, and we have a graphic of that article if anyone wants to actually go and check that one out as well. But where do we stand right now with this link between hearing loss and cognitive decline or dementia, however you want to classify it?
Yeah, so this becomes remarkably thick very quickly, because when we talk about hearing loss, as Rachel mentioned, we have 38 million people in the USA who have hearing loss if we were to test them on an audiogram, right? But then there's another 26 million people who have no hearing loss whatsoever on an audiogram, but they have listening disorders. It could be auditory processing disorders, could be auditory neuropathy spectrum disorder, cochlear synaptopathy, hidden hearing loss, traumatic brain injury, ADD, which is attention deficit disorder, attention deficit hyperactivity disorder. There's a million things, right? So we have 26 million people who have no hearing loss whatsoever, but they have listening difficulties. So how does this all correlate with cognitive decline? Well, Rachel, you mentioned that at age 65, your chance of having demonstrable hearing loss is about 1/3. By age 75, it's 2/3 of Americans. Those are almost the exact same statistics for cognitive decline. When you think about mild cognitive impairment, which is the stage between normal healthy aging and dementia, when you think about that, people with mild cognitive impairment above age 65, it's about 22% of the American population. Wow. So it's huge.
That's huge.
Yeah, and so the population with cognitive impairment and dementia, mild cognitive impairment, those folks, and the people with hearing loss and listening disorders overlap tremendously. It's the exact same demographic. So there was a study out of the UK, it's called the UK Biobank study, came out, I want to say in 20 or 21, I think 21, and they looked at 82,000 people. And what they found through those 82,000 people followed, I think it was 12 years on average, The people who had the worst speech and noise scores, the people who had the most difficult time understanding speech and noise, had a 65% hazard ratio for having earlier dementia. So it doesn't mean that if you have bad speech and noise that you're going to have dementia. It doesn't mean that at all. It means that they measure things that are similar. There are things that will line up in those. And so it's important to do a speech and noise test because audiologists, hearing aid dispensers, otolaryngologists, that's part of our best practices, whether you're looking at IHS, whether you're looking at AAA, whether you're looking at ASHA, they all say the same thing. What they say is after all of your diagnostic work, you should be doing a listening and communication assessment. And I know, Cliff, you talk about this all the time. These are things like the COSI, Client-Oriented Scale of Intervention, the HHIE, Hearing Healthcare Inventory for Elderly. This would include the International Outcomes Inventory. These are things that don't measure hearing specifically, but they measure how is the patient doing in the real world. So these are functional assessments.
Yeah.
And all three of the major groups also say you should be doing a speech and noise test. And that speech and noise test tells you a lot. Some people will say to me at lectures, well, we know everybody has a difficult time in speech and noise, so why bother measuring it? And the answer is that if you measure it, you know exactly what amplification to fit them with. And that's kind of a remarkable statement, but turns out to be pretty much true. And if we know that somebody has, and Cliff, you've talked about this in your earlier programs, it's called an SNR 50, which is the signal to noise ratio to get 50% of the words correct. If their scores are 2 or 3, that's pretty normal. But if it's 5, 6, 7, then they're acting like somebody that has a moderate hearing loss. And if their scores are 7, 8, 9, 10, that's a severe to profound loss. Well, by knowing their ability to understand speech and noise, that tells you what quality amplification you need. Because when people think that, well, now that we have OTC, all hearing aids are the same, I'm just going to buy the one that I can afford, I'm going to buy the one that looks the best, I'm going to buy the one that's... The single most important issue is how do you do unaided versus how do you do aided, and in particular in noise. That's what lines up with mild cognitive impairment and different dementias, is that the biobank study showed a 65% hazard ratio between speech and noise and cognitive difficulties.
Well, it's kind of interesting because that particular test to do the 2-minute speech and noise test to identify what the SNR 50 is, you can do that on individuals with normal hearing. So you had just mentioned, like, if you're doing just a standard testing protocol on someone who's having hearing difficulty and they don't have a measurable hearing loss from a threshold perspective, you can actually, and we fit people with hearing aids who have completely normal hearing, and we tested them with the speech and noise test to identify, like, would they gain benefit with hearing aids. And so not only is it like an age-related issue, you know, for hearing loss and all of that, or an identifiable hearing loss through a regular test that you would do, but a lot of people would say with cognitive decline is that, well, of course, like if you're going to get older, you're going to get dementia more likely, and if you get older, you're going to get hearing loss more likely. So how do we kind of discuss that topic with individuals who are debating whether or not this link is legitimate?
Well, again, we have 26 million people, Americans, who are going to not have any hearing loss, that are going to experience these problems. We know that as you age, you are more likely to have hearing loss, you're more likely to have cognitive decline. Exactly right. But the thing is that if we can make the signal-to-noise ratio better, if we can make it so that you can focus more easily on the primary speaker that you want to pay attention to while hearing the noise less significantly, we are doing something called, we're reducing the cognitive load. We're making it easier for you to pay attention. And the easier it is for you to pay attention, the more likely you're going to listen effectively. When you're in a cocktail party, it's a very, very difficult environment, particularly for older people, particularly for people with hearing loss. But if they have the technologies that you guys speak about, and they're getting a better signal-to-noise ratio, it's remarkably easy. You know, when you think about this pragmatically, a lot of people will take issue with, oh, I never fit people who don't have hearing loss. Here's something that we should all think about. Right now, when you look at all the 5 major hearing aid manufacturers, and you look at the VA, and you look at all the retail bricks and mortar stores, we sell annually only about 5 million hearing aids a year. That may sound like a lot. It's not a lot. Population of America is 335 million people, so you know it's not a lot.
And they all have 2 ears.
And they all have 2 ears.
Yeah.
So when we sell, 4 to 5 million hearing aids, or we distribute, because when I say 5 million, I'm including the VA. That's an interesting number to know. Now, the more interesting number to know is that if you Google Apple AirPod, they sold 100 million units. So while we're discussing should we or shouldn't we fit people, based on their audiogram, there's 100 million sales that occurred, and I'm not blasting Apple. I think that I wear my AirPods all the time. In fact, they're in my pocket now. But it makes it easier to listen because they have noise reduction, because it gives me a better signal-to-noise ratio. It's a higher quality of sound. It's more easy to speak on a telephone. So all of those advantages, why I think everybody in this room probably has AirPods, is what people with listening disorders go through as well. Is if we can make it easier to listen, it's more amenable to their lifestyle and gives them more information that they couldn't access otherwise.
Yeah, I often have patients who maybe have spouses or family members, and I'm trying to explain this idea of listening fatigue and try to explain kind of what the person's going through, because they see it, right? There's this withdrawal from the conversation, and there's this, they kind of sit back and smile and nod. But I say, have you ever had a phone call with someone on the other end of the phone that had a really, really thick accent? And the phone call was about 2 minutes long, and that for that entire 2-minute length of time, you're just sweating, right? You're like, oh, what is that? And you ask for repetition 3 or 4 times. It starts getting awkward and uncomfortable because you're still not understanding. And you hang up that phone call and you go, oh,
right.
That was a long one. But can you imagine doing that in nearly every single environment all day long?
Right, and those are the people who are seeking the AirPods, I think, generally speaking, because they're looking for a better sound quality, they're looking for a better signal-to-noise ratio, they're looking to understand more easily, less stress on your brain and your central nervous system to focus. When you go to doctoral programs in audiology, you learn about the value of these things: intraoral loudness differences, intraoral timing differences, the importance of signal-to-noise ratio. But I do want to make clear, I'm not advocating, and I know you guys aren't either, advocating just put hearing aids on everybody. Nobody's saying that. What we're saying is we should test deeper, we should test comprehensively, because when somebody comes in and they complain that they can't understand speech and noise, best practices, International Hearing Society, American Academy of Audiology, American Speech Language Hearing Association says you really should be doing a speech and noise test. And it's just the only way to understand what the patient is going through. And you do that with or without hearing loss. So hearing is perceiving sound. Hearing is just detecting sound. Listening is understanding sound. Listening is assigning meaning to sound. And this is the difference. When people have difficulty with listening, they attribute it to hearing, right? You go to Thanksgiving 2 or 3 weeks ago, and maybe your dad or your grandfather or your spouse couldn't understand all the conversation, and so we say, it's just his hearing loss. Well, it may well be, and that would make good sense. But how do we know that that's it unless we actually do a speech and noise test?
And that's exactly why we really started the Hearing Up Provider Network, and where we started vetting providers throughout the country, making sure that they're following comprehensive best practices. And the ones that I encourage people to follow is the AAA best practice guidelines. So we have these providers throughout the entire country, and one of the things that is a requirement to be in the network is that you're doing speech and noise testing on every single one of the patients, regardless of if they're even reporting difficulty in background noise or not.
Yeah, and those guidelines are being rewritten now because they're a little bit older. And kudos to Mike Valente and his writing group for putting that together, because it was a brilliant document. And I think even though they're older, they're just as true today as they were then. The only thing that's changed is the technology. Now it's actually easier to do all that work.
Yeah, absolutely.
Yeah, we just did our last episode was on assistive listening devices and also being able to improve signal-to-noise ratio and in a variety of environments in a way that more traditional or earlier hearing aids were not able to do. And it's like we've got the technology to really handle a lot of these more difficult listening environments much better than we were able to previously.
And a great take-home message, I think, for consumers who might be watching this program is that it's not so much about hearing. I mean, hearing is the foundation. You have to hear it to listen. But hearing is just step one. Listening is the whole thing. Listening is when your brain can perceive the sounds that your ears are delivering and make sense of it. Because that's the goal, is understanding speech in difficult listening situations. So we have to make it audible, we have to make it loud. That's hearing, not too loud, but loud enough that it's audible to the individual. And then we have to make it of sufficient signal-to-noise ratio such that the person's brain can decode that signal and make sense of it.
Right. When you talk about signal-to-noise ratio, just in case individuals don't understand what that concept is that it's the signal, which is what you want to hear, versus the noise, which is what you don't want to hear, or that's interfering. And so we want to separate those. We want to have a really good signal-to-noise ratio.
Right.
And the fun thing that I talk about all the time is that a lot of people think that it's like, oh, well, it's a shot in the dark. Well, it's not. Like, we
It's
can
not.
measure all of this stuff. You were talking about SNR 50 again, right? Where we can actually measure, like, where are you at in your SNR 50, and that
Right.
predicts how well you would do and what technology we need to go with to
Exactly.
actually treat you, right?
Yeah, and you know, the test that you're talking about, the 2-minute test, we wrote that one in 2019. That was Dr. Lauren Benitez and I wrote that one. But there have been speech and noise tests that are, you know, probably the most common one is the Quicksin, which was Meade Killian. And for the audiologists, hearing aid dispensers, otolaryngologists, that was 2001 when Meade wrote that Seminars in Hearing on that. So, you know, we've had this technology for a long time. It's not like it just came out.
Yeah, absolutely. Definitely not new. Well, we're going to get into this topic here a little bit more. But what we're going to do first, we're going to jump into our next sponsor.
All right, our next sponsor here is Eosera. So Eosera's got an entire comprehensive line of ear care products. We use the Earwax MD in our clinic. We've also talked about Ear Itch MD, and we've talked about Ear Pain MD. Today I wanted to talk a little bit about the Ear View MD camera. And so this is actually a video otoscope that does hook up wirelessly to your smartphone so that you can look inside of your ears. And this allows you to take pictures and videos of your ear canal, and you can even visualize your own ear drums. So if you think that you've got earwax buildup issues and you want to see if what you suspect is true, this is one way to do that. Our audiology assistant recently was pretty sick and could feel this pressure build up in her head, and normally she works around a bunch of audiologists, but this happened to be over the weekend, and it was to the point where she could barely kind of hear out of one ear, and she wanted to take a look in there. So she was able to actually use that EarView MD camera to look in the ears herself. There was no denying that the middle ear space was full and infected and angry on camera, and so she went, okay, I am not being dramatic. I'm going to go to the doctor and get some meds, and she did that. So definitely, if this is something of interest to you as well, or any of their ear care products, you can visit eosera.com and use promo code CLIFF20. That will get you 20% off of your entire purchase. So thank you,
Awesome.
Eosera.
Thank you, Eosera. All right. So, Doug, you were about to say something. Can you remember what you were about to interject with?
I don't think I've. So two things. Number one, we talked about hearing versus listening, and we talked about those numbers. And then we migrated to some other topics that are very, very important. And among them was that hearing aids. I was making the argument that we are not saying to fit everybody in the world with hearing aids. What we're saying is that even if you have no hearing loss, what you want to do is get a speech and noise test, because if you're complaining about speech and noise difficulty, that could be the key to your successful future, is to know what you need in order to pay attention, in order to listen clearly. And if you can do that with a simple 2-minute test, that's sort of magical, and it changes your life. Now, based on that, then you could see an audiologist or a hearing aid dispenser or an ENT who then, based on that information, would let you try something. Whether or not you have demonstrable hearing loss on an audiogram is not the single most important issue. The issue is how are you doing in life.
Yep. It all comes down to really patient rapport, quite honestly, because I have experienced this as well, especially when we start talking about other populations like you were speaking about earlier, with concussion or with a traumatic brain injury, or with attention deficit disorders. Like, this is not just individuals with hearing loss, and there are many, many individuals out there that could benefit from having just a slight amount of amplification to really separate out speech from noise and allow them better access to that sound and less auditory fatigue, pretty much listening fatigue, rather.
Yeah, and it gets us back to cognition, because hearing is, basically occurs in the superior temporal lobe, which is right about here. But listening, attributing meaning to sound, is a whole brain event. It involves, the occipital lobe. Right now, the folks watching, you're watching, it makes it easier to understand because your eyes are being processed in the back of your head at the occipital lobe. You have the frontal lobe, which is your emotional centers. You have the temporal lobe, which is your hearing center. So when you're listening, when you're trying to understand speech and noise, it's not just a simple hearing event. It's an entire brain event.
Yeah, I had a patient today actually who I took into the booth, and he said very quickly, I don't like this test. I don't like these tests. And I said, why? And he goes, because it's not real world. You're going to ask me to press a button when I hear a beep, and that's not how I'm actually doing. And I
Good
said,
for him.
And I said, and yeah, I was like, good, advocate for yourself, say how this isn't truly representative of how you are actually navigating through life. And I said, well, don't you worry, we're going to put you through a speech and noise test here, and I have a feeling that you're going to see real quick that's going to replicate a little bit more of those natural environments that you're in.
Sure.
And he got a 16 on the
Okay,
Quicksen,
well,
right? So he's really struggling.
He's struggling,
But
yeah.
in the past, the audiograms have been a moderate to severe, and every audiologist has just told him up until this point, well, your hearing aids are well fit, and you are where you need to be, and just wear them more and do
Right.
better.
Yeah, we can do better. We
We
can
can
do
do
better.
a lot
Yeah.
better than that. Definitely.
Go ahead.
I was like,
about
go
to-
for it.
yeah. You can go for
Okay,
it.
well, really, we were talking about, I guess this would be considered more of a screener for those higher level processing abilities in the office, not necessarily a screener through the Quicksen, but we have these speech and noise tests that can tell us how listening and processing and hearing are all kind of integrating together.
Sure.
But I want to get into this topic now about cognitive screening, because
Sure.
you had another article here, and this is an extremely long title, but we've got the emerging relationship between cognition and audition. And I think that that's really, really interesting, why cognitive screenings can be beneficial for patients that have hearing loss, and why these more comprehensive hearing tests are really recommended for individuals with mild cognitive impairment.
Yeah, so this is a huge issue. When we're talking about patients who may or may not have cognitive issues, it's so easy for us to do a cognitive screening. I mean, they take 5 to 10 minutes, and in particular, when you're dealing with an audiologist, an otolaryngologist, a hearing aid dispenser, when you're dealing with those areas of expertise, those disciplines, most of the patients that we see have hearing loss, right? That's why they come to see us. But when we're doing a cognitive screening, it becomes remarkably important to be able to take hearing out of the picture. Now, here's why. About 15 years ago, I wrote an article with Carol Flexer, and she was a past president of the American Academy of Audiology. And what we said that listening is where hearing meets brain. That was the title of the article. And what happens is it's so important to be able to test somebody without their hearing getting in the way. What we said in that article 15 years ago is that when people were getting cognitive screenings, when they were getting a cognitive diagnostic test or a screener, big problem was that a lot of the symptoms from hearing loss masquerade as cognitive issues.
Yeah.
And that wasn't a new observation then, because Patricia Krikos wrote about that 10 years prior. And so when we see patients with hearing loss, we would like to use a cognitive screener that does not involve an auditory stimuli. What Carol Flexer and I were arguing back then is that you don't know which patient is having problems with auditory processing or with hearing loss. And a lot of people pushed back and they said, oh, I can tell who has hearing loss. And it makes no sense. There's 26 million people with listening problems that have no hearing loss. How can you tell? And if I can't tell, and if Rachel can't tell, and if Cliff can't tell, how can a psychologist tell
No.
who has virtually no more training in audiology than I have in psychology? I mean,
Yeah.
it's a silly concept when you think about it. Is that we need to say, before we do a cognitive screening, it would be really, really wise to do a complete audiometric evaluation, make sure the patient is hearing and listening properly, and then you can assess them.
Yeah.
Now, there are articles that have just come out this past year looking at even using simple things like a pocket talker, which is a very simple assistive listening device made by Williams Sound. It's brilliant. It's very inexpensive. Just adding 10 or 15 decibels of gain to virtually anybody, they do better on a cognitive screening.
Yeah.
So this is kind of a remarkable finding. And the question is, well, then how much of that do you attribute to their assistive listening device versus their own? Their own ability is totally fine to use once you know what it is. But if you don't know what it is, you're guessing. And there's just no room for guessing in medical science. I mean, those days
No.
are over. We can test people. We can send them for a complete audiometric evaluation, a speech and noise score, and then do a screening after that, which doesn't involve hearing. So that was, the Cognitive View Thrive is particularly good at that because it's a computer-driven, self-contained cognitive screening, and it doesn't have any auditory cues. So what happens is it's totally visual and motoric. They move a little cognitive wheel, which
Oh,
is not
yeah,
the
We
let's
even
show
have
a
an
little
overlay of
video of
that
it.
to kind of show what that would look like when someone's
Yeah.
taking the test.
Right.
So what's he doing right there?
So what he's doing there is he's trying to trace the highlighted dots, and the more competent you are at doing this, the harder the test becomes. So you don't expect anybody to ever score 100% because it's adaptive. If you're really slow and you're having a hard time, it stays really slow and it accommodates what you're doing. If you're really, really competent at this, the machine will understand that you're doing very well and it'll make it more difficult. So you have this broad range of 0 to 100 on performance. And what you're actually measuring are things like visual, spatial, you're looking at executive function, you're looking at memory, and these are just cognitive screeners, but if you do great on it, we're very comfortable saying you did fine. We're not really particularly concerned about a cognitive issue. We know that your difficulty understanding speech and noise is primarily auditory, because we've ruled out the most basic cognitive functions. And you know, the screeners have been around for a long time, but most of them involve me or whoever the tester is reading a list of questions, and then that person responds based on what they can hear and listen to, and then I have to interpret what they're saying, and then I score it. So you have tester bias, 2 opportunities for that in the exam, and then I score it based on my interpretation of what you said.
Now, how long would a screener like that take, like a manual screener?
Well, Cliff, I think you used to do the MoCA, right? The Montreal Cognitive Assessment. And in competent hands, when you're comfortable with it, you know, it's 8 to 10 minutes, maybe 12 minutes. It depends on how rapidly the patient responds and how well.
And it takes the time of the clinician too.
Oh yeah,
well, right?
This is an issue, right? Is that if you're doing traditional testing, mini mental state exam, the mini-cog, the MoCA, which is the Montreal Cognitive Assessment, the SLUMS, which is the St. Louis University Mental Scale. When you're doing any of those, they take time of the tester and the person being tested. When you're doing the Cognitive Thrive, that's automated. You're not really involved. You're sitting the patient down, you're telling them, please follow the instructions on the screen. You're done. It automatically scores, it automatically evaluates, it kicks out a report for the physician. In case they do have non-normative results, you have a report that you can send to the physician saying, here's how they did, so we would recommend, you know, further evaluation. And it's up to the physician. I mean, that's his or her role in this. You know, audiologists, hearing aid dispensers, we're not diagnosticians with regard to cognitive screeners. But it's the same thing that we do in so many areas. When I was starting to do cochlear implant research back in the early 80s, before the FDA approved cochlear implants, I would do Snell and eye charts to check patients' vision, because we knew that if somebody had good hearing and good vision, they were much more likely to do well with a cochlear implant than if somebody had poor vision. So we would make sure that I would test their vision. And we do the same thing, you know, as far as referring. We do that in audiology every day, in hearing aid dispensing every day. You're looking for patients who have middle ear disease. You're looking for patients who have asymmetries. You're looking for patients who have just tinnitus in one ear. You're looking for all of these warning signs of things that could be dangerous or they could benefit from medical or surgical intervention. So we're very used to getting test results and then referring when necessary. And if, you know, certainly audiologists and dispensers, if they don't find any red flags, you know, they can go on and take care of the patient as their state license allows them to do. But if they see any of those things, they refer all the time. So it's not unusual. But the thing that has brought it, I think, into the mainstream in 2022 and into 2023 is this correlation between what we do in speech and noise and our demographic, primarily people in their 60s, 70s, 80s, with the same demographic in cognitive screening. And the same complaints. The complaints could be, I don't understand what somebody just said. I can't understand speech and noise. I'm not sure what they meant by that. You know, so you have all of those same sort of signs and symptoms, and you have the overlapping demographics. So what many of us are advocating is that it would be a wise thing to do while you're speaking to them about communication, about speech and noise, about understanding what people are saying. Do a cognitive screening, spend the 5 minutes, and then you can rule that in as something that should be referred, or you can rule it out and you don't have to deal with it.
Yeah, I mean, I think so often we talk about, you know, wishing that audiometric screening and evaluation overall was implemented more often than it is, from even just a primary care physician standpoint, getting more of that screening over. But we have a very unique position where we are also engaging with the same exact patient demographic, and if they hadn't already been screened for these types of things with their primary care physician or at their annual wellness visits, this is just another point of contact from a healthcare provider where we can implement this and, you know, if we could, oh, we've got this stat on this. If we could, you're going to have to help me say it prettier. If we could move up the diagnosis of a mild neurocognitive decline by a year, then by the year 2050, we could reduce the overall rates by
10%.
10%, yeah. That's
which is huge when you start talking about the mass of individuals that we were talked about earlier, right?
Yeah, that's you said it very well. I can't say
good.
it prettier.
Thank you.
But if we diagnose, so this gets back to Livingston 2020, Gil Livingston's article in the Lancet, that if we can diagnose these people even 1 year earlier, by the time 2050 rolls around, instead of having roughly 155 million people with dementia, we might have 10% less. Because we would address their modifiable risk factors.
Yeah.
And all of them won't be saved by that, but about 40% we would expect improvement.
We get accused, I've been accused of this on my YouTube channel because I've created a number of videos, either in collaboration with Cognivue, with their screening tool, or just on my own. And people say that I'm fear-mongering when I say that they should be treating their hearing loss.
Yeah, so, well, one of the things you mentioned was screenings, and this is a really hot topic. I just published a paper in the ASHA today. What's it called? ASHA Leader, November-December issue, and I argued that I don't think we should be screening everybody for hearing loss. I do think we should be testing people through comprehensive tests. Here's the thing: if I had like a little nodule right here, and it didn't really hurt, and it wasn't really much of it was just a little thing. And I go see my physician, I say, I have this little bump here, what do you think? He or she is gonna say, well, I think that's your parotid gland. You know, and about 80% of those little bumps are non-carcinogenic. They're not going to become cancerous. They are benign. But we don't know on that one. So what we're going to do is get a fine needle aspiration. We're going to stick a needle in there and get some cells, or we're going to get an MRI, or we're going to get a CT scan. None of them would say, oh, yeah, well, we'll keep an eye on that. Nobody does that. What they would do is they would get a diagnostic test.
Yeah.
And it's really important because it could be the difference between life and death. So nobody's going to say, I'm not going to get a fine needle aspiration. I'll roll the dice on that. And if it's a parotid, and I'm not an expert on parotid, I'm just using that as an example. But the point is, if you have a virus and you go see your physician, he or she is going to do your vitals, they're going to check your history, they're going to do all that, and then they're going to probably order a CBC, a complete blood cell count, and look at your white cell count and all this stuff. Nobody's going to say, oh, it's just sniffles, you probably have a cold. We don't do that anymore. So here's the thing, when we have hearing loss, we tend to say, oh, it's normal, everybody, and first of all, everybody doesn't have hearing loss. 38 million people have hearing loss. That means the vast majority of Americans don't have hearing loss. Does it occur with aging? Absolutely. Is it a normal occurrence with aging? Not necessarily. So we need to investigate these things. And when we talk about cognitive decline and the risk of not diagnosing while it's mild cognitive impairment, if we wait until it's more substantial and somebody actually has dementia, at the point of dementia, the options are very much reduced. You know, there are no medicines that are working magically at this point. You know, we look at some biomarkers, we look at amyloid plaques, we look at tau proteins, we look at these things. But there's no one-to-one correlation with dementia. In fact, there are some people who have tremendous amyloid plaques throughout their body, their central nervous system, and they have no dementia whatsoever. So it's certainly not a one-to-one. The same is true of tau proteins. These are important, and you know, there are different alleles that we've looked at that might become the sign and symptom that tells us you're in trouble, something's going to happen. But we don't really have that at this moment. And what it is mostly when we talk about the difference between mild cognitive impairment and dementia, you know, it's a clinical decision. It's much like Meniere's disease. When a physician says, well, I see that you have fluctuating here, low frequency loss, you have tinnitus, you have dizziness, you probably have Meniere's disease. There's no test. There's no one test. It's a clinical diagnosis. And this is true at this moment, I believe, as well with cognitive decline. When somebody has dementia, that is a clinical diagnosis. There's not a lab test that says yes or no. There are lab tests that are very, very useful, and probably the most useful are the PET scans. And anyway, in the paper that you talked about, I go into those in detail. But But most of us aren't going to get PET scans done. Most of the time, it's going to be a clinical diagnosis, hopefully from a physician who might specialize in this, like a gerontologist or perhaps a geriatrician or a family medicine doctor who's particularly involved in these sorts of things. Because these are very, very difficult diagnoses to make. Because oftentimes, when you have somebody who doesn't score well, you don't have a baseline measure. So you'll get a patient who's, let's say, 76 years old, and they come in and you screen them, and they don't do well. But the question is, how do you know that might be how that person's been forever? And so it's important, I think, to get a baseline. And then I don't know if you need to do it every single year, but it would be good, I think, when we're doing hearing aid evaluations, when we're doing comprehensive audiometric evaluations, spend the other 5 minutes, do a cognitive screening. If they did great, fantastic. If they didn't do well, refer them back to their GP. But I think that's the important. I don't think it's fear mongering. I think it's realizing that these can be tip of the iceberg situations. Yeah. Much like patient with unilateral tinnitus. It's probably nothing. Could be an acoustic neuroma. It could be a brain tumor, but it's probably nothing. And if you said it's probably nothing, you'd be right most of the time. Patient with a brain tumor that you missed, well, that's going to be a shame.
Yeah,
right.
Yeah, for sure.
Right.
Now, if everyone watching right now, if you're not overly impressed with the knowledge that Dr. Beck has, you should be, and you should take this opportunity to ask your questions on this video. And we're going to be able to answer those questions for you. So as long as it's contextual to this idea of hearing loss and cognition, hearing loss and dementia, so on and so forth, it is right in his wheelhouse. So I won't be able to answer a lot of those questions if you wait till future episodes. So take the opportunity right now and ask those questions, okay? But do you think that treating hearing loss is going to have a positive impact on the rates of dementia in the future?
Yes. There are a lot of studies that have shown that when we fit amplification appropriately and correctly and professionally, that the patient benefits. Mm-hmm. And these benefits are not just cognitive. We can go back to the Anu Sharma and Hannah Glick study, Trends in Neuroscience, where they were looking at about 24 people, and they showed that there were anatomical and physiologic benefits from wearing hearing aids every day for 6 months.
That's what we referenced on our episode previously.
And it's a brilliant study,
Yeah.
and if you want to read the quick and easy version of it, you can go to hearingreview.com and put in Anu, A-N-U is her first name, Sharma, S-H-A-R-M-A, comma, Douglas Beck, and you'll pull up the interview I did with her in 2020. It was just the same week that peer-reviewed article came out, but Dr. Sharma and I did a 2,000-word version of it. So it's just the greatest hits of that article. But that's not the only one. I mean, you go back to Franklin's work from 10 years ago showing that people with hearing loss have a higher opportunity for cognitive decline and dementias. And there are many studies. If you go to that emerging relationship between cognition and audition, you'll see I name about 10 or 12 studies that have shown amplification in certain individuals has tended to improve their cognitive abilities. Now, there's a brand new study that just came out also in the Lancet this past week that said, well, when you're doing screenings, you do tend to get people who appear to have more hearing loss, and they do poorly on screenings, and you're catching those. But do they actually go on to have more dementia? And they threw that up as a good flag for all of us to think about. So again, we're not the experts in this. We can do the screenings. We can say positive or negative, normative or non-normative. But that's the job of the neuropsychologist, the neurologist, the psychologist, the psychiatrist. Those people will make that decision. But I think that, Cliff, you mentioned, is this fear-mongering? I think in medicine, when you order a CBC, the reason you're doing that is the exact same situation. You know that it could be very bad. It probably isn't. And same with CT scans, same with MRIs, same with most blood tests. We have to put ourselves in the position of the patient, and the patient is coming to us for our expertise and our knowledge, and to pretend we know not as much is not ethical and fair.
What's the negative, right? Well, the negative would be is that it costs money potentially to treat your hearing loss, depending on insurance coverage, depending if you're a veteran who has VA benefits, at least here in the United States. Time. So if you go to a hearing care professional who follows best practices, it takes significantly more time to go through treatment with them than it does to someone who doesn't. But if you want it done the right way, right? And so like time and money is the thing, but there's positive consequences to it as well.
Yeah, there are. And as a matter of fact, I would argue with you on that there are articles, Sergei Kochkin wrote an article a few years back where he was talking about if you do best practices, you spend a lot less time in the audiologist's office. So I don't remember.
I remember that because it was verification and validation is what they looked at, right? And if you do verification, it means that you have X amount of less visits that you go to. If you do both verification and validation, it cuts it down even more. I remember
it was about
that
one third.
I just know a lot of patients who come into us. We're like, hey, we're going to take you through this comprehensive best practice fitting sequence, and it's going to be about 4.5 hours of your time. And they're like, well, the last place I got hearing aids, I only went in for one 30-minute appointment, and then I was done for 4 years.
Sure, and that could be great. If you don't have anything else going on, and if you know that, then quick is good, But the problem is that in all of medicine, and I taught at medical schools for a lot of years, St. Louis University, every freshman medical student knows this. Diagnosis first, treatment second. And my fear as an audiologist is we find patterns that we're particularly used to, like mild to moderate sensory neural hearing loss, which is the inner ear loss that accompanies aging and or noise-induced hearing loss. They look very much the same. So we see that and we say, oh, that's why you have a problem. Well, that's probably right, probably. But it could be something else. And this becomes a professional odyssey. I mean, we don't want to test to the nth degree, but we can ask a reasonable question. Is your inability to understand speech and noise due to hearing, or is it something else? So generally, hearing care professionals have just looked at the hearing end of it, and now we have these tools that in 5 or 10 minutes, we can do a quick cognitive screening. I think that's patient-centered care, that's holistic care, and when the patients are coming to us, and particularly the patients who have no demonstrable hearing loss, they have no audiometric hearing loss, but they're complaining. What we've done traditionally is we do these 3 things. I call it the happy talk. We tell them, sit closer, pay more attention, and better lighting. But we never did a speech and noise test. We never did a communication and listening assessment. And we certainly didn't do a cognitive screening. So I'm thinking if we were to actually do that, which is what, and again, most of the things I just mentioned are best practices from the 3 national groups. If we were to actually do that, it might take a little longer. It might cost a little more, but we might help a lot more people.
Yeah, for sure. Well, we're going to get into some of your guys' questions here in just a minute, but before we do, we're going to talk about our last sponsor here. So over-the-counter hearing aids are finally here, and over-the-counter hearing aids can help if you have a mild to moderate hearing loss, so it's worth checking out. But not all devices are created equal, which is why you should check out the Sontro over-the-counter hearing aid. The Sontro was developed by Soundwave Hearing out of Oak Brook, Illinois. The Sontro is a receiver and canal design, and the AutoTune app that it works with is used to test your hearing and program your own Sontro over-the-counter hearing aids, which makes it possible to customize your own audio settings. Now, if you're going to be doing over-the-counter, probably a good idea to at least get some kind of an evaluation here to make sure that you don't have an acoustic neuroma growing on your auditory nerve. And one of the great things about that particular app is that it was able to identify for me that I had an asymmetry between my 2 ears. Now, if you want to see how the Sontro did in my review, I do have a video review of that particular device on my YouTube channel, so make sure that you check that out. And if you want more information about their product, you can head over to hearsoundwave.com. All right, question time.
Question time. Hello, Kelsey.
Hello. It is really great to be on the show today. We have had an extreme amount of engagement and a lot of questions to get through. I did my best to compile them. I even combined a few questions to try to get through even more of them, so bear with me, but we've got a lot of interesting questions coming from our audience today. Our first question is kind of a combo, kind of a story. I asked my neurosurgeon about this relationship between cognitive decline and hearing loss, and he said that as far as he is concerned, there is no correlation between hearing loss and dementia. My grandmother died of dementia, and she did not have any hearing loss. What is the distinction?
Whenever you talk about a neurosurgeon, you have to understand that what he or she does for a living is surgery. They are not cognitive neuroscientists. They are not audiologists. They didn't go to school for 8 years studying what we study for 8 years. And so it's a different mindset. And I don't mean any disrespect to neurosurgeons. In fact, 2 of my very best friends in life are neurosurgeons. That's not my point. My point is, if you come to ask me about plumbing, I'm probably not going to have a good answer for you. If you come and ask an audiologist about meteorology, you know, we all go outside and we can see the weather, right?
Right.
But the meteorologist probably knows a lot more about it. When you go to an audiologist who has an undergraduate degree, like about 98% of us do, in communication disorders, this is actually our area of expertise. It's the foundation upon which our master's and our doctoral degree programs were built, is based on communication disorders. And we also studied speech and language as undergraduates. So I'm not going to say the neurosurgeon's wrong. I'm not ever going to say that. But I'm going to say he might be a little out of his lane because in his experience as a surgeon, he doesn't see that connection. Well, how would he?
Yeah.
Yeah, it's not related to what he does day in, day out, whereas someone who does this day in, day out, does the research, who treats, hearing loss,
Right.
who sees it in person day in, day out, is going to have a very different experience, both anecdotally and in the research that they're familiar with, because we're reading the research that pertains to us and our patients. Versus someone who is reading, about how to perform brain surgery.
Right.
I don't read that article because I'm not out there performing brain surgery.
That's exactly it. And again, I wouldn't have any issue with if a neurosurgeon wants to express his opinion. That's fantastic, and I'm always interested in what they have to say.
Mm-hmm.
But he could argue with the Lancet 2020. Dr. Gil Livingston and colleagues. There's about 65 co-authors on that. I don't think he would be successful in arguing there's no connection.
Yeah,
I
definitely.
think it's pretty well established.
Yeah. Great. Okay, so is the link between dementia and hearing loss surprising if this person already has hearing aids? Now, this is a bit of an interesting question because I think, lost in translation somewhere in here too. I think more, is there still a risk, is my interpretation from the following conversation that ensued online once you're treated with hearing aids.
Hearing aids don't necessarily prevent dementia.
Right.
And very few people are arguing that you should wear hearing aids to prevent or slow the progression of dementia. That is not a known or a fact or a given at this point. We know that untreated hearing loss certainly causes problems in quality of life, in social isolation, in memory. There was a very famous study in 1999, National Council of Aging looked at about 1,500 people with hearing loss who were treated with hearing aids and about 1,500 people who chose not to get treatment. And if you look at them a year or two later, very, very different in depression, in anxiety, in stress, and all these other things. But nobody's going to say, nobody that I'm aware of would say, oh, we should fit you with hearing aids to prevent cognitive decline. We don't know that to be true. There will be studies in the next year or two that are going to come out. And I think in the very short term, Johns Hopkins study should be coming out pretty soon, which is based on 900 people at 4 centers across the USA. Some of those patients got hearing aids, some didn't. And then we'll be able to make stronger statements about are hearing aids truly protective? Now, there are absolutely studies that have shown some patients, sometime, really do improve cognitively with hearing aids. But we don't know which patient that is. We don't know how to select who's the most appropriate patient for that rehab. And we also don't know who's less likely to succeed with that technique. So we're just at the beginning. What we know is that hearing loss certainly does appear in hundreds of peer-reviewed articles to be associated with cognitive decline and mild cognitive impairment and eventually dementia. What we don't have good data on is how much does a hearing aid help. We know that untreated, it's going to not be good, and treating it certainly makes good intuitive sense. And there certainly are papers that have shown treating it does help certain people certain times, like we talked about the Anu Sharma, Hannah Glick paper earlier. But there are many others. I mean, there's literally hundreds. I have a brand new paper coming out in the Hearing Review in January, so in 2 or 3 weeks, where I think I go through about 15 papers that were published in 2022 addressing the correlation between hearing loss and cognitive decline. So wearing hearing aids, does that prevent or slow it down? It might in some people, but we can't be sure of that. We know that untreated hearing loss is definitely not a good thing.
Well, that's why we say potentially modifiable risk factor,
Yeah.
right? I mean, potentially it's modifiable to address that potential, that risk and mitigate it to some degree. And hopefully it does, because if we can get rid of 8 to 9% of that risk factor for from midlife towards end of life, I guess, or later in life, I guess we would say, why wouldn't you want to do that, right? So So I think that it's interesting. The research, like you said, is coming out in droves now to where we're actually going to have some more hard data to be basing these recommendations on.
Sure. And I think we're all going to benefit from that. I don't think there's any doubt in my mind that it's a good idea to let a patient try amplification, see how they do. And we were talking about this earlier in terms of like auditory processing disorders, listening disorders, things like that. And I think that when you have a patient who doesn't do well on a cognitive screening, it might be an option. But we have to be careful, because when you see a cognitive screening failure, that is a non-normative result, just an assistive listening device will probably get you a better score. So when people test rapidly and they do a repeat test 30 days later, and they do a cognitive screening 30 days after they were fit, they're probably going to do better. But to me, the reason that they're probably going to do better is essentially you have improved their sensory system. You're making them more aware of their surroundings. You've benefited their hearing and listening ability. So that's cool. But is that truly a cognitive change? And that we don't know. That is something that would be a diagnostic evaluation by the appropriate professional. I mean, we're doing screenings. So what we don't want to do is attribute more meaning to them than they deserve.
Right. Has there been, so this was a question submitted by another professional, has there been research to suggest that not only speech and noise testing, but also tests for central auditory processing disorder, things like the Listen-S and those tests as well, showing any differentiation between cognitive decline, global processing, and auditory processing, and what that relation may be?
Yeah, so the Listen-S, that's the listening and spatialized noise. That was Sharon Cameron and Harvey Dillon came out with that. That's a brilliant test. I love that test. I have no idea if anybody has tested that with regard to cognitive abilities.
I'd be very interested to see that. I fail it every time. I have ADHD, and I'm not good at that test.
Well,
so I'm curious to know if, in addition to that, there's some implications as far as cognitive decline, dementia, hearing loss, and how that's all related, because listening is, like you were saying earlier, an entire brain process.
Right, exactly. And so I hate to punt on that one, but Sharon Cameron, when she wrote that, I think she's still at National Acoustic Labs in Australia, as is Harvey Dillon's retired, but they would be the ones who would know whether they have looked at that in regards to cognitive decline. I think it's absolutely brilliant. I've advocated that test for more than a decade now. I think it came out 2010, and I think it's absolutely brilliant, but I don't know if it correlates at all.
I think we got time for one more question if you've got one. I'm sure you do. You
If
probably have
I've
20.
got one.
Which leads me to believe that we should try to see if we can get you back on in the future,
Sure.
Either in person or virtually, because obviously there's a lot more information up in that head of yours that we want to pull out and extract if at all possible. But
I was going to say we could talk about music, and that would be,
Oh yeah, well then you'd lose me completely. So, yeah.
We'll talk about music.
All right.
Okay, so if the brain is without sound for a long time, and then the brain gets sound back, will the brain be able to process that sound, or will it do that kind of processing at a slower rate because the brain has not been stimulated?
Right. So these are fascinating questions. This gets to the issue of neuroplasticity, and it gets also to auditory deprivation. So there are studies that have shown some of these things. For instance, if you go to the City University of New York in the late or mid-'80s, Shlomo Silman did work there, City University of New York, showing that if you had relatively symmetric hearing and symmetric word recognition scores, and you put a hearing aid on one ear, that one ear would maintain those word recognition scores, but the untreated ear would get worse over the years. And so we don't have a lot of data showing what happens when you put hearing aids on people as far as long-term results with regard to brain degradation. And these are the areas that are emerging now. I think you're going to see the ACHIEVE study. That was the one out of Hopkins. That's going to just be fertile ground for another 50 studies, I'm sure.
Right.
A lot of these things, you have to understand that this is a relatively new area for audiologists. And so the hearing questions, the listening questions related to cognition, a lot of them we don't have answers for. We have intuition and we have our best suspicions, but that's not the same thing as having a good scientific answer.
Yeah.
Right.
So I would say, if you read the question one more time. So I gave you the Shlomo Silman part, but I forgot where you were.
Does the brain process that sound at a slower rate
Oh.
because it's not been stimulated?
So that's what I was saying about neuroplasticity, is that everybody who goes through rehab has a unique problem, and once they have a solution, they have a unique solution. You could have, and every audiologist knows this, you could have 25 people with the exact same hearing loss on an audiogram. They're going to wind up with 25 different devices, set 25 different ways, because we're setting it up ideally for that patient to
Right.
maximize their hearing and listening. This is part of the problem with OTC, is that, if the patient can program it themselves, they'll program it to what they like and what seems to be best. That's great, no issue with that. But it may be that when you set it to where you really, really like it, that's not a maximal setting. Because we
Right.
know that the brain will change based on sensory exposure. So we talked about auditory deprivation, but then you have neuroplasticity. So if we rehab and we provide that sound, everybody's going to get a different result. I'm pretty sure. We don't have a lot of science peer-reviewed data on that, but I think that neuroplasticity is magical. And you can take patients who've had major strokes, where they were paralyzed on half their body, and over 6 to 12 months later, some of them are going to rehab fantastically well. Others will not rehab at all.
Right.
This is true in virtually every area of medicine, that the goal is often not rehabilitation per se, but it's prevention. And this is what we found from the National Cancer Institute, is that trying to cure cancer is very, very difficult. We still, we've made incredible strides there, but the bigger stride has been made in prevention, right? Is get people to eat healthy diets, to exercise, to not smoke. And so if you prevent the cancer, that's better than trying to cure it later.
Right.
Neuroplasticity it speaks in some of the same language, that if we provide a good solution, everybody's answer is going to be a little bit different. And we can't predict exactly who's going to respond maximally, although we have trends, right? And so one of the things that we did with hearing aids in the last 10 or 15 years is most of the hearing aid manufacturers went into extended bandwidths, where they went, instead of to 6,000 hertz, they might go out to 10 or 12,000 hertz. And many people said, oh, I can't tell the difference. No. But I think the speech and noise scores are much better for people who have a full spectral response, even though they, of their own accord, can't tell. But you and I can measure that. So.
Right.
So I think that really what we should be gleaning from this entire discussion today is that we do have a pretty strong link between hearing loss, dementia, cognitive decline, all of that.
Sure.
Screening, not as important as like full-on audiometric testing, like
Right.
get speech and noise testing, big part of that. If you can find a provider who does cognitive screening, that's
Yep.
probably the best way that we know how to do cognition screening at this point.
Yeah.
And then, audiologists are really front line of defense on
Yeah,
that
they
right
really
now.
are. I mean, we're the patient advocate. We're looking for patient-centered care. We're looking for holistic treatment of the patient as a human being, not as a set of ears. And so I think it's incumbent on us to look deeper.
Absolutely. Well, I appreciate you coming out. I
Yes,
mean,
definitely.
flew out here to be on the show. So
Absolutely,
we
my
greatly
pleasure.
appreciate you, and it was worth every minute of it, I must tell you. And hopefully it was worth it for you, too.
I'm absolutely thrilled to be here. Thank you so much.
Awesome. All right, guys. Well, that's all the time that we have for today. If you want to check out our live show every single week, it is at 4 p.m. Arizona time. You can find us on Facebook Live, YouTube Live, and WTSMTV.com. And as always, we'll see you next week.